Good afternoon, distinguished speakers and colleagues. Ladies and gentlemen, thank you every one of you to join us today. I'm Dr. Xiaonong Zhou, the Director of the National Institute of Parasitic Disease at the China CDC and the Chinese Center for Tropical Disease Research based in Shanghai. First of all, as co-chair of the Surveillance and Response Working Group of AppMan, I would like to welcome all of you to participate in this Tech Talk webinar hosted by the Surveillance and Response Working Group in order to address the cross-border malaria transmissions, challenges, and best practice from the Asia Pacific and beyond. It is with great pleasure for me to announce that from 2023 to 2024, I will be taking on the role as co-chair of the Surveillance and Response Working Group alongside Professor Richard Maud, who has been steering the working group for the past 2 years with Mahedo Oxford Tropical Medicine Research Unit, or MORU, as the host institution. With this change, we are hopeful to re-energize the working group as a peer-led knowledge sharing and technical exchange platform. I'm so excited to bring in the expertise that is behind the China CDC to enhance and continue to deliver activities that are of priority to malaria elimination and of relevance to both the AppMan national programs and the partner institutions. Last month, the Asia Pacific Leaders Conclave on Malaria Elimination highlighted the number of key challenges experiences across the region. One major theme that emerged was the challenge with the targeting mobile and migrant risk populations and addressing the issue of cross-border malaria. Cross-border malaria is a complex and multi-faceted issue with many factors contribute to the high receptivity and low interventions coverage. The movement of mobile and migrant populations across borders is a significant fact that can lead to the reintroduction of the disease into the areas that have successfully reduced or eliminated malaria transmission. At the same time, Anopheles mosquito never has passport, so mosquito can fly more than 2 kilometers around its habitats to easily cross the border for transmission of malaria. So to eliminate malaria, we need a coordinated efforts across multiple countries, and effective cross-border cooperations and strategies are crucial. Yesterday, I visited Yunnan province, where bordering with Myanmar with more than 4,000 kilometers of borderline. So lessons learned from Yunnan malaria elimination program from 2010 to 2020. Once solving the problem of cross-border malaria in one country or a region, it is not only able to accelerate the national malaria elimination program, but also able to consolidate the achievements in a country where malaria has been eliminated. So in this Surveillance Response Working Group Tech Talk, we have an excellent lineup of panel speakers who will share their experiences and interventions in addressing cross-border malaria in various transmission settings. For example, the first one will be the Dr. Jingwei Xu, will share China's experiences in addressing cross-border malaria in the past elimination phase. And Dr. Andrew Sikora from Brazil will describe the unique challenges and interventions used to address cross-border malaria in the Amazon border. And Dr. Ilesa Handawati from Indonesia will present the primary findings on operational research funded by APMA on cross-border cooperation in Indonesia. Finally, my co-chair, Professor Richard Maud from MORU, will be facilitating this session. Thanks to the Professor Richard Mulder. And last but not least, Appleman is a Appleman is a form that gathers all the lead researchers and implementers working toward malaria elimination in our region. We look forward to learning from these experts and engage in fruitful discussion on how we can effectively address cross-border malaria transmission. Thank you once again for joining us today. Thank you.
Thank you, Professor Zhang, for your opening remarks. Thank you so much. So just before we begin, I'll inform you about the mechanics of this webinar. Audio and video will be disabled for attendees, but you're encouraged to comment in the chat box and submit questions in the Q&A box at the bottom, as well as upvote questions. So you can vote on the questions that you see to see which ones you most want to be answered during the webinar. And following the presentations by all three speakers, I'll then moderate a Q&A session where we'll address the questions that have the most votes. And we'll have a bit of a discussion between the panel speakers. And then right at the end, there'll be a poll that will pop up on your screens to ask about your interest to connect with the speakers for more information about their work. And we're also setting up a special interest group on cross-border malaria and surveillance in mobile and migrant populations as a sub-working group under ATMEN for interested partners to share best practices and consult on challenges in each of your respective settings. So our first speaker is Professor Jianwei Zhu on behalf of Yunnan Institute of Parasitic Diseases, China. Over to Professor Zhu.
I think there's a chance that Professor Su has disconnected.
Yeah, looks like the connection has just dropped. So while we're waiting for him to reconnect, we'll go to our second speaker, which is Andre Sequeira from Brazil. Hi, Andre. So if you'd like to share your screen, you're welcome to start.
I believe Andre might have disconnected.
No, it's also dropped.
Oh
Must be an internet. Let's try Elsa, and we'll come back to the other speakers later. Elsa from Gadjah Mada University, Indonesia.
Yes, hello, Prof. Richard. So I
Hello.
start now?
Yes, please. Is that okay?
Yeah.
Thank
okay.
you. We'll reconnect the others later.
Yeah.
Thank you.
So is it already there, my screen, Professor?
Yes, thank you. You're on mute. Dr. Elsa, can you take it off mute so we can hear you?
Okay, is it okay? My voice is
Yes,
okay?
perfect. Thank you.
Okay.
Yes.
Yeah. So good afternoon, everyone. So first, I would like to say thank you for inviting me in these tech talks. Here, I would like to share our preliminary finding of cross-border collaborations in Indonesia, Timor-Leste, and also in the operational research plan that's supported by Appleman. So it's not working. Okay, so I think all of you already know where is Indonesia, and from this picture here, we see that Indonesia actually shares border with other countries. for the land border that we share, we have with Malaysia, with Brunei, with Papua New Guinea, and also with Timor-Leste. Of course, each border has its challenge in the context of malaria. And at the border with Timor-Leste, it's also interesting because malaria here actually is not quite prominent. So West Timor, as part of this Timor-Leste, I want to show you, this is the Timor Island. Here we have two countries here. This one, West Timor, is belong to Indonesia, and this one is belong to Timor-Leste. And what happened in West Timor is, as a part of Nusa Tenggara Timur or Indonesia, we have here, there are 5 districts and then most of them, actually the annual parasite incident is lower than 1 mil. While in Timor-Leste, it's they almost reach the malaria elimination, certified malaria free in 2020, but unfortunately failed because of new malaria cases that were introduced that suspected maybe from the neighbor here. So here is the cross-border actually, yeah, at the West Timor and also the Timor-Leste. Here we have in the border 50 villages from the Indonesian sides. And from this Pelu here, it has around 220,000 population. And in Malacca here, the district in Indonesia, it has the around 200,000 populations. In Pelu, actually, the cases from 2020 to 2021 is actually has decreased so much. For example, only 47 cases in 2019 and then become 24 in 2020 and 2 in 2021. And it's not indigenous cases. Meanwhile, in Malacca, and below the Pelu district, is also similar decrease of malaria cases in 65 in 2020, and it became 38 in 2021. And people in the Pelu and Malacca district here, they mostly work as a farmer, construction worker, and in mining. And this is not only work here, but also sometimes they went to other province of Indonesia. They go to, let's say, to Kalimantan, to Papua, but sometimes also Malaysia and also cross to Timor-Leste to sending goods to Timor-Leste or just doing local market activities or has family business. Because as we know that actually there is a great family ties at the cross-border area. So just for example, for wedding ceremony, religious ceremony, religious ceremony, or even though it's just building a house, they invite their families from other part, from the other countries. Let's say from Pelu, they can go to Timor-Leste, and from the Timor-Leste, they can go to Pelu. So here we see there is a dot, a red dot here. Here we have a modern, what we call like cross-border post or cross-border office at Pelu and one cross-border office at Malacca, which in a day it can be 300 people that cross this cross-border post. So we can see that we can imagine the mobile, there is a mobilization, of the people from here to the other, to the adjacent cross-border. This is just from the formal one. For the other, from the traditional cross-border, and also from the porous location, which is illegal, it can be more than 300 a day. So here I would like to highlight our previous findings about the cooperation between Indonesia and Timor-Leste in malaria disease control in border areas, but especially our own reflection from Indonesia. So this has become important, the collaborations, because otherwise, if it's not solved, then there will be a tension between the country. Actually, we already have this MOU, the commitment, the MOU first signing in Geneva from Indonesia and for Indonesia and Timor-Leste in 2017. And then there is follow-up with the daily declarations, not only for malaria, but also for other infectious disease. And in 2019, there is an action plan that should be the details point from the MOU, and including what should be discussed at the border area. And 2020, unfortunately, there is a report concern from the Timor-Leste to NTT or Nusa Tenggara Timur Malaria Program Officer that there is an imported malaria case from Indonesia. So we have the study previously that using qualitative method, we interview the stakeholder at the national level, province level, and also district level. And we found some interesting finding. The first about the MOU itself. The MOU, even though there is already exists, but there is no, it's not established yet the institutional structure in the MOU. We actually also have joint border committee, but it should be instruction that follow it up, but it's not yet available. So we can say that despite the MOU, the good bilateral relations between the two countries were not seen in the case of imported malaria. I'm sorry, but it's okay. Yes. The other finding is about the complexity of the structure of the authority at national level, and also the bureaucracy and health system. So, for example, persons that have like malaria, we catch it in the cross-border office, it will go to the cross-border office, it will go to the joint border committee, and it will go up to the Ministry of Internal Affairs, then go to the Foreign Affairs. But the cases that gets at the community, it will go to the public health center, and then go to the district health center, and go to the provincial health center and Ministry of Health, and also the Ministry of Internal Affairs. However, this is also not a clear mechanism about this. And then we say here that it should be a clear flow or pathway to mitigate the malaria at cross-border. And there is also the it also need involvement of different authorities in reporting health system malaria, make it simplify the bureaucratic part in mitigating malaria cross-border problem, and also provide the available SOP. And then giving the lesson learned with the COVID last time, I think it's also interesting if more authority is given to the local government to take early action, while at the same time it report to the central authority. So we happy that after this study finished, then there is also a study that gets support by the APELMA to conduct the operational research for these cross-border collaborations. So the aim of this study is to explore the intervention that relating to the malaria data sharing across Belu Bobonara. Bobonara is the adjacent district that's belong to Timor-Leste. We choose that area between the countries, and we will develop the procedure. And the second one, we would like to assess the migration surveillance procedures across the border and also provide the recommendations. So actually at the kick-off meeting this year, Indonesian sites already developed the report flow within the country, but in the future, it's also need the same flow like this from our neighbor from Timor-Leste. And then after that, we get the agreement, hopefully, on the data sharing mechanism and platform that will be used in the mechanism, data sharing mechanism. For example, we can choose correspondent letter, email, WhatsApp, or maybe digitalized platform. And also, it is also important to determine the turnaround time, the response time. The other is also the clarity about the data that will be shared by the two countries. Yeah. Besides the lack of reporting the pathways, the reported data, as mentioned above, also has minimal information. And here by the study, in the next study, we will assess what already exists there, and then we will see the gap and the barrier, or maybe we can fill the gaps and giving the recommendation for the surveillance, minimum data surveillance that should be have. So here it just what's that report, a study coming from Brazil. That's they define first what is actually the malaria import, because this is very important to determine what it means with the importation. Internationally imported, transnational, or just locally imported. So we can see, or we can decide it is just autochthonous, or this is really an international import malaria. So I think this is important also to decrease the tension and blame each other. The data, it should have like a minimum data indicator that should be agreed between the two countries. From Brazil, we learned that the data need to be reported is the date and location of notification, the location of the resident, and also most likely location of the infection. If the point, the likely location of infection is not available, maybe it also need the date of the travel, the date of the first symptoms that must be collected to deduce the most likely location of infections. Of course, there will be many challenges in the surveillance of the data. For example, the completeness of the data or the human resources also. So the operational research that will be done in these months, yeah. Hopefully this month we can start to do this operational research. It is also participatory research action approach. It means that we involve the stakeholder to also identify the gap, the barrier, and also giving their suggestion to make the recommendation. So recommendation for the study, especially ones, how to do the data sharing mechanism, and secondly, what data of the surveillance migration that should be there, especially at the cross-border area. So this is the testing intervention. We have two interventions for joint data sharing mechanism. We first explore the pathway from the both countries, and then test out just one pathway that already agreed as guided by the consultation with the respective countries. And then the second one, we will assess the migration surveillance at the border area. We assess the existing intervention, and then after that, we will do the surveillance migration. We'll give the recommendation for the joint activities of surveillance migration. I think that's my presentation, and I'm also thanks to my team member that also contribute to this result and also the proposal of the study. Thank you very much, Prof. Richards.
Great talk. Quick reminder to the audience to put any questions in the Q&A box, and we'll take them after all three speakers are finished. And just to apologize that we've changed the order of the speakers, but everyone has now been able to rejoin. So we'll continue with our next speaker, Professor Jianwei Zhu from YPD in China.
Hello, can you hear?
Yes, perfectly.
Hello?
Thank you.
Yes,
Welcome.
thank you. So hello everyone. I'm Jianwei Xu from YPD. It's a pleasure to share some experience and lessons in border malaria control and elimination in renown province. In China, border malaria problem only happened in the renown province. So my presentation is about this kind of experience. Today we're talking about this 4 points about this 4 points. Next. So firstly, I just introduce some background in Renown. Renown province shares 2,060 kilometers border lines with Myanmar, Laos, and Vietnam. Just like show on these pictures, those border areas, no natural border barriers. That many people can cross the borders. So the spatial location and the complexity of vector ecology, imply malaria control and elimination is very challenging. The border malaria was originally malaria endemics, anophelines are still existing now. So this continue this background introduction. Until 2023, a total of 15431 cases was reported in Renown province. In April 2016, the last indigenous malaria cases was reported. So from 2017, Renown interrupted the malaria transmission, and no local infection till now. In 2020, Renown was certified malaria free by China Health Commissions, and in June 2021, China was certified malaria free by the WHO. As everyone knows, there are 3 China's malaria kind imported from the neighboring countries in the border areas. First is the people from malaria endemic countries or regions. Second is the people who travel to other endemic areas and getting infected. The infection return to non-malaria areas. The third is the mosquitoes infected with malaria parasites. Can imported malaria to the non-malaria areas too. Can anopheline mosquito imported malaria? In the survey, yes, it can imported malaria by the mosquitoes, but still lack of the data. In the Renown province, in November 2019, a story of 239 workers who from malaria freeze in an embankment construction project on the China-Myanmar borders provided this kind of data. Because the outbreak was not close to any communities or residential sites on China's side of the border, but to the internally displaced persons campers in the Myanmar side along the border river bank. So just you can see from this satellite map, then China said that no any communities or residential sites. Just the Myanmar side, the red dots is called RDP campus. RDP campus. The number just show that China's work teams, team 15, team 16, team 17, team 18 work on the river bandits. So this picture shows this is the river. This is RDP campus. So this is the project set. So in this picture, this is the China workers hands. And here is the Myanmar's RDP caps. This is inside of the times of China works. In this set is before the intervention, they do not use bed nets. This after the intervention, they use the bed nets. So this story provides the evidence for mosquito can cause the transborder malaria because this outbreak says is nearly 20 kilometers from the nearest Chinese communities in China said. This study, this investigation also showed that the reservoir of primary cells and the distance to endemic communities of neighboring countries, namely within travel distance of female mosquitoes, are two determining factors when we considering broad-spectrum malaria. In the WHO's malaria-free certification for China, the WHO accepted those cases were imported malaria by the Anopheles mosquitoes. Back to this, as said that the present reservoir is a main determinant, one of the main determinants of cross-border malaria transmission by mosquitoes. For example, we found 22 workers infected in this malaria outbreak. Most of them is infected in the team 15 and 16. They near to this RDP camper. This RDP camper have more malaria prevalence. So this story tells us that mosquitoes can transport malaria across the borderline. First on this three channels of malaria transport of malaria importation from neighbor country. We developed the 3+1 strategies for malaria control and elimination. So the strategy one is the intensive interventions within 2.5 kilometers along the border to prevent border-spectrum malaria. Here we give a name this kind of malaria caused by the mosquitoes border-spectrum malaria. So border-spectrum malaria is caused by the infected Anopheles mosquitoes from the neighboring countries. Second strategy is a community-based malaria detection and response in the frontier townships. The strategy 3 is universal coverage of malaria surveillance to detect malaria kills in frontier counties. The +1 is called solid collaboration with neighboring countries. So next, I will introduce strategy one by one. So the strategy 1-to-1 within the 2.5 kilometers along the borders to prevent the migrants and the malaria spear borders. Why we use the 2.5 kilometers? Because based on the summary of 291 anopheles mosquitoes market release recapture experiments, then 143 localities around the world. The mosquitoes, anopheles mosquitoes can fly as far as 2.5 kilometers from each other. So in these areas, if the communities in the neighboring countries is still hyper-endemics, we should use the control interventions, not the elimination activities. These activities include active and passive parasite detection, malaria case detection, intensive vector surveillance. Based on the surveillance of vector, if the vector's density is high, maybe cause the both spear malaria transmission, we need to use the vector control measures such as RRS. Of course, in these areas, we also deliver the long-lasting badnets to the local peoples. If the vector control measures cannot control the both spear malaria, sometimes we give the preventive treatment with the anti-malaria drugs. Second is about the strategic activities about the strategic tool. Because in China, the frontier townships can present some unpermitted border process. Those people going to China through the non-formal border process. Then the official border process, we can have the immigration control. But then this kind of areas is difficult to control people across the borders. So in order to properly detect molecules and response among migrants, intensive malaria surveillance and response should be maintained. The activities including passive malaria detection in the township hospitals, village leaders and health workers monitoring border closures and referring February patients to the township hospital for testing malaria. Then the county CDC maintaining regular active case detection. That is the interventions strategy 3. Strategy 3, we call that it's a health facility-based surveillance for any malaria cures. The second is the county CDC central rapid response to any malaria cures. So the passive detection should be consolidated into the normal health service. In this service, we should maintain the vigilance of health personnel, especially the clinical doctors. If this health facility in China, merely the public hospitals do the test for malaria, but some selected private hospitals, they like to join the surveillance. So the government can give them incentives, training form, Then fixed the web-based Chinese information system terminals for them. For the village and private clinics, also the drugstores refer the suspected malaria cases to the county CDC or to the public hospitals. When any malaria, any people will test positivity, when the county CDC give the rapid response. So the response follow the China's 137 strategies. So first is within 1 day, report the malaria. Then the 3 days, the CDC confirmed the body test by microscopy the malaria and do the individual case epidemiology service. If needed, the county CDC conduct the response activity detection. If found that mosquitoes, they give the intervention. For example, RRS to kill the mosquitoes. So that is the activities in the strategy 4. Strategy 3. Second is about the it's about the +1. +1 is the collaboration with the neighboring countries. Also, China neighboring 3 countries. In fact, in the northern part of Vietnam and Laos, the malaria is nearly eliminated, so it's not a problem. But the malaria is a problem, is merely in the China-Myanmar border areas. So in the early 2005, China and Myanmar signed an agreement on cross-border malaria controls, especially from the 2007 to 2013. With the support of the Global Fund, China successfully conducted a malaria project round 6 and round 10. This 2 projects effectively reduced the malaria burden 90 in the 5% regions of Myanmar and 95 in the Chinese borders. In this 2 program, China allocate most of the funds to the Myanmar side. This activity is carried out by an international NGO, Health Poverty Action. At last, only 3 hotspots is left in the Myanmar's border areas. It's this red stars. One is in the Kachin state, and now is the Salween River Valley. Then there is small good triangles. So this cooperation is helpful for China's malaria elimination in the renowned border areas. About the 1+3+1 strategies are just give 3 experience. First, in the elimination and preventing reintroductions, surveillance and rapid response are the key interventions. Second, we should nuclear the goal and the interventions for malaria control and elimination is very different. It's very different. The goal of elimination, the goal of control is reduce the malaria abundant, both treatment and preventive interventions. So this is a population-based intervention. But the goal of elimination is to interrupt and prevent local malaria transmission with an appropriate surveillance and response system. When the border areas of neighboring country is still have endemic, the integrated control measures, not the case-based surveillance and response, are still necessary within 2.5 kilometer water perimeters along the borders to prevent malaria spread into the eliminated areas. Then they said that is experience about the cross-border collaboration. In fact, cross-border collaboration is easy to show, but it's difficult to carry out. Sometimes, even the central government of both countries have agreed some activities, but you need the agreement by level. For example, even today, two countries agree on activities. Maybe 1 year, the activities cannot effectively carried out. So then right now, to make these things more easy, the central government of both countries can decide on agreement framework and import corresponding local government agencies, include civil societies organizations like NGO, to carry out activities with mutual benefits. So then the global fund for the global fund projects of course China Myanmar border areas will use the NGO to carry out the activities. I also talk about the 3 lessons. For the malaria control and control in the border areas, sustainability of malaria control need a political stability in the border areas. 2 countries. Now then part of Myanmar, in fact, it's have some military conflicts. So in recent years, in fact, Myanmar said malaria incidence is increasing now. The second is about the reduction in the vigilance for malaria control among the local people and the health personnel, especially the clinical doctors, can lead to delayed detection of the imported malaria, the increasing risk of malaria reintroduction. So the third is border collaboration is practical intervention. Like just some training, meeting, data sharing may not reduce the malaria incidence in the border areas of neighboring countries, and then increase risk of malaria introduction. In fact, because the COVID-19 pandemic, the number of malaria cases increased from 2636 in 2019 to 7404 in 2020. Then the Myanmar border areas neighboring China. This data is from the NGO HPA. It's a global fund project. Thank you very much. This is my presentation. Thank you, everyone.
Thank you very much for your talk. Excellent stuff. We'll come back to the end. You'll see that there's a few questions appearing in the chat. You're welcome to type answers. We'll choose the questions with the most votes to try and address verbally. We'll move swiftly on to our next speaker, who is Andrea Sequeira from Fiocruz in Brazil. And just to say thank you to Andrea for joining us in the middle of the night. I'm aware it's not the best time for you, but over to you, and we're ready for your talk.
So good night from here, and good morning and good afternoon for all of you across Asia. It's a pleasure to be participating. Actually, I think Asia and America, especially Latin America, they share a lot of similarities, but the distance and especially the time difference sometimes make it difficult for us to interact more, but I think we can do that. So I'm going to share a little bit of the experience we are having in the cross-border malaria in the Amazon, mainly in the northern part of the Amazon, where there is what we call the Guiana Shield, which is this area where we have Guyana, French Guiana, Suriname, Brazil, Venezuela, Colombia, and there's a lot of people movement in this area. So malaria in Latin America, it concentrates mostly in forest and rural areas, apart from the coast of Colombia, where there is some hotspots of transmission. Mostly we have land borders across countries, so it's easy for people to cross it. They don't have to go through migration posts, although there are some, but there's no need for visa or other migrant barriers. Transmission is, of course, highly heterogeneous, but it's more intense in near border areas, where we see the red areas are municipalities with high transmission intensity, and they are all cross borders here. We have Venezuela, Guyana, Suriname, and so on. There is also an area with high rates of illegal activities, mainly related to mining fields, and there are a lack of cross-country surveillance agreement and cooperation, which makes difficult to have proper estimates of border malaria in the region. And it's an area with increasing worry about risk of anti-malaria resistance emergence, especially some evidence on artemisinin resistance as well, but that's something that still needs to be better addressed, and that's something we need to learn more about Southeast Asia, where you guys have led the way through. So there's high intensity cross-border movement in the area, and I will highlight the issue from Venezuela. So there have been more than 800,000 legal migrants and refugees in the last decade. They are seeking health and economic assistance due to the country's economic crisis. So here we see up to 2020, the high in this purple line, the high number of migrants from Venezuela coming to Brazil and entering social services. So more this data is being updated constantly, but more than 1 million Venezuelans have left the country. And the border between Venezuela, so here's Venezuela, Guyana, and here's Roraima State in Brazil, where we have been working, and there are more than around 1,200 people crossing the border daily through the migration zones, where they are registered and they receive assistance, but there are also people crossing outside these official entering spots. So 200 to 300 apply for refugee status, and more than 40,000 are living in camps. And there's a lot of other problems apart from malaria, like the outbreaks of measles, whooping cough due to low vaccine coverage, and other infectious diseases as well. And related to malaria, the data from from Venezuela, for example, it's very scarce, but these are the estimates of 2017. Especially, I'm showing here the Amazonian states that border Guyana and Brazil. So they are considered the hotspots of malaria transmission, also with a lot of illegal mining working there. And in this map over here, this bottom one, we see the contribution of Venezuela to the malaria cases in each municipality. So each of these circles correspond to a area of municipalities. Some of them are very large, but here is the neighboring, here are the roads, and here's the main entering site. So here in Pacaraima, for example, 90% of malaria cases are from Venezuela, because they have also faced crises with diagnostic tests and anti-malarial treatments lacking in their health system. So people had to cross the border to receive simple, come from very far, sometimes many days of infection. So some of them severe, but also through a long infection and transmitting to the local mosquitoes as well. Here in this graph I show the high contribution of Venezuela migrants to malaria cases in that particular state. So we see that especially during 2018 was the highest number of cases reported. There was some action made in 2019 in terms of active case detection in the area that reduced importantly the number of cases, but mainly what had led to reduction was political aspects. So from 2019 onwards, Brazil had a right-wing government, while Venezuela had a left-wing government, and they had broken diplomatic relationships. So the border was closed for a long period of time. So this led to this reduction in the number of malaria cases from Venezuela being diagnosed in Brazil from Venezuela. There was a major reduction in 2020, 21, and mainly 22 because of the border being closed during the COVID pandemic and also due to diplomatic issues. But the borders have been reopened, and we are seeing an increasing number of malaria cases from Venezuela. Now, as this data is only from up to March, but the last 2 months, it has more than 5 times this number of cases. So more than 700 cases in 2023 are from Venezuela. So there's this increasing trend of migration again. Another aspect that's important to understand the region is related to illegal mining activities. Most of the illegal mining is done in indigenous reserves where it's shouldn't be allowed, but there was no policing during the last 4 years. So there was a huge increase in mining activities in this area. So there are no state activities related to safety and also health. The living conditions in these mining fields is very precarious. So there's no walls in these housing facilities. They sleep in hammocks. Here we see one place where bed nets were distributed, but mainly there are no bed nets. There are no diagnosis and treatment on site. So there is the circulation of counterfeit drugs in these mining fields, and in which people are using usually 1 or 2 days of treatment without testing, only because they had fever, and they don't complete treatment because they want to save it if they have another fever episode to take the medicines because it's very expensive inside the mining areas. It's like 1 gram of gold, which would be around $50, for example. Here's just showing the mining areas in Brazil. So here we see these different landscapes and different metals that can be explored, and just a simple depiction of that. The areas in green are indigenous reserve areas, and in which any of these activities are allowed. And in this orange color, it's the areas where there are noble metals and diamonds and gold, for example, and they overlap a lot these areas. So that's why there is this avidity for miners to go inside these areas and try to do practice, though it's illegal. So when we see the picture of imported cases in Brazil coming from neighboring countries, most of them come from Venezuela and Guyana. They are from this area of the Guyana, what we call the Guyana Shield, and the great majority, up to 98% of malaria that is imported from these countries are from Brazilian residents. So they're mainly miners or people doing mining related activities are going to these countries. They stay there for days, weeks, or months, and then when they come back, having usually incomplete treatments, they are suffering from disease for long periods of time, and they are diagnosed and treated for malaria in Brazil. And here we see, for example, the effect of this mining activities on indigenous malaria, mainly the Yanomami reserve. Some of you may have seen. So this is the number of tests and cases reported between 2000 and 2022. And as I said, from 2018 onwards, there was a huge increase up to 2021. What happens a lot is a lot of underdiagnosed and under-reporting of malaria cases because there is a lack of infrastructure for testing and they are not being reported. So that's a failure of the surveillance and information system. But there was an increase in positivity rate related also to a reduction in testing. So most cases that are being tested are highly suspicious of malaria. So it's not a lot of active case detection being performed in this area currently. And this also has resulted in a worrying increase in Plasmodium falciparum cases proportion. So around 37% of malaria in the northern part of Brazil, in the bordering area, is due to falciparum, although in Brazil overall, about 9.5% of cases are due to PF, and 95% are vivax. So this is something related to this long periods of infection, the long interval from initiation of symptoms to diagnosis and treatment, and lack of other control and elimination activities. I mentioned the worry on anti-malaria effectiveness. So we have been seeing high rates of recurrence amongst patients being followed in the region. So we coordinate studies being done in these bordering areas, and we see, and when in these cohorts, we observed 30% recurrence of vivax within 60 days and 10 to 16% of falciparum, which we are doing the molecular testing to evaluate if they are reinfection or of treatment failures, but it's highly worrying due to what I mentioned, the high transmission rate and also the circulation of counterfeit drugs and lack of adherence. So there are few studies, and they've been done a long time ago for measuring parasite clearance time for falciparum. And we are currently doing a study in the border of Brazil with Venezuela and Guyana to have more information on that. There has been, since the new government came to Brazil, there's been a lot of army and police activity in the indigenous reserve. So this is they saying out with the miners from the land, and there's been a lot of conflict in the area between the army and miners, and a lot of miners, they are leaving the indigenous reserves and going to other countries. And as a consequence of that, for example, Suriname, which is a neighbor country in the Guyana Shield that has a very intense malaria program for elimination funded by the Global Fund. They have not reported any autochthonous case in the last 18 months, and all of the cases were vivax. But the malaria cases occur in mining areas. There is also illegal, but they have implemented diagnosis and treatment through mining workers, either miners or shop owners or other people folks working in the mining fields. So they do diagnosis and treatment on site in the mining areas, and they report these cases through WhatsApp to the central level, which will perform reactive activities according to what occurs. So they are also doing active case detection with border process in this area, because they are on the path for elimination and trying to advance on that. But we have recently been there, and there's been an increase in the number of cases reported. It's low numbers still, but most of them come from Brazil. Most of them come from illegal mining sites where they have gone through miners have gone through Suriname because of more, let's say, friendly environment, and they are starting to see falciparum cases there as well, which is also they are very worried about, and this has led to a movement of higher cooperation between countries. It's very preliminary, but the idea is to try to merge or share information systems and data, and also have joint activities for active case detection, testing of border process, and a movement to have molecular testing for a better understanding the dynamics of people and parasites in the area. So the challenge and actions in this border region is that these illegal activities make it difficult to track the trends, epidemiological trends. There's a lot of unreliable information and data from miners, so they lie sometimes when asked about where they've been, and it makes an effort to have better information on where malaria transmission is actually occurring, and the lack of state in these illegal areas that makes it difficult for better actions. There's this risk and worrying risk of antimalarial resistance emergence and increase. We need to better evaluate the active case detection and active surveillance that's done in few locations in the border areas that can be an important activity. There are some initiatives of providing RDTs and ACTs to miners that will cross the borders. They receive RDTs and ACTs, but with this, the impact has not been assessed so far. There is a multi-country country effort now trying to evaluate these actions and see how they work and if they do work, how they can be implemented. And we do need better surveillance and information system integration for joint strategies. We have a lot of ongoing activities in this field, and we are conducting that with a lot of partners and funders. And thank you for that. I'm happy to answer anything.
Thanks, Andrew. Fantastic talk. And I can see lots of parallels with our experiences in Asia Pacific. So we will go straight to the Q&A, just a few more minutes. Thank you for the speakers for answering in the Q&A box. There's lots of questions. We don't have time to address them all, but we will we'll collect them all together with the responses as well. But if you vote for which questions you want to be answered directly just now, you go into the Q&A box and then click the little thumbs up sign. But we'll start with a question for Dr. Elsa from Shobi-chan. Does Indonesia malaria migration surveillance program also test asymptomatic people from bordering countries? And if you find any cases from those countries in Indonesia, how do you treat them?
Okay, that's the question from Subia Aldila Wulandari, is that right? So thank
Yes,
you,
that's right, yes.
Wulandari, on the question. So from our experience when we visit the cross-border post, so there the people with symptom, so only people with symptom or with fever, not all people come from bordering will be tested. Perhaps because first, this is the limitation of the RTT. And then the second one, maybe there is no available instruction yet for who to test, the person that to test. It should be, for example, it can come from the receptive area. So maybe because there is no instruction, the test is just for the persons with the symptomatic or fever. And then about the treatment, we use here ACT, artemisinin combined therapy. And then usually for the persons that cross the area entering the Indonesia, and then it will be referred to the primary health care that become the destination of that person. I think that's free charge my answer for Wulandari. Thank you.
Right, thank you. Okay, next question. So Mohammed has asked a few questions, but I noticed one of them was about dealing with asymptomatic human subjects and cross-border movement of asymptomatic malaria. So I wondered, Andre, if you wanted to say something about that.
Yeah, that's a very interesting and important issue. So we do have seen outbreaks, especially in indigenous communities, from people with that have crossed for festivals, indigenous festivals. So there was an outbreak in Suriname with 50 people with what was classified as introduced malaria. They came from Brazil and they introduced that in Suriname. And this highlights how testing for border crossers asymptomatic infection is important. So that's something that has been evaluated recently, and I participate with that with some Suriname colleagues. We haven't published that yet, and it's preliminary data, but it's a low yield activity. So we test a lot of people especially in elimination settings, to detect very few positives, but this can have a very important effect. So this can be improved if information on the area where they are coming from, what's the transmission intensity in there. But indeed, it's something to be evaluated in each context if testing is the more adequate option, but sometimes even the active treatment of border crosses can be a good measure if low parasite density infections are prevalent in the area and that will not be detected through microscopy or RDT. So that's been shown as well.
All right, thank you. And related to that, it looks like Professor Wei was just about to answer in the chat. Is that a question about the sensitivity of RDTs, sensitivity and specificity of RDTs for cross-border malaria? Professor Jiang Wei, would you like to answer that one? Yeah, he's on mute. There.
Yeah. There.
Okay, thank you. I can see you've just answered it in the chat. You've said RDT is useful for passive detection, passive case detection. Okay, well, in the interest of time, we will move to the poll, but just like to say thank you very much to the three panelists, three speakers. I think it's been a really great session. We'll have some follow-up as well, but we'll just have a little poll appear on your screen to ask for your feedback and also a couple of questions about some of our future directions as well. So hopefully it's showing up now. Yeah, I can see it. So we're also asking if you'd like to have further contact with the speakers to learn more about their work, so that'll pop up soon. And then we mentioned earlier about this new ATMEN SRWG special interest group on surveillance and response for cross-border malaria. So the goal of that is to share best practices and go into some more depth on this topic, and also a venue for countries and organizations to consult on challenges that they're facing around cross-border malaria in their setting. So you can also express your interest through the poll for that. In the meanwhile, we've still got a couple of open questions. Yeah, there's a question about, do we have a link for the interest group? So we will be asking you in the poll in a sec to register your interest, and then we'll reach out with more information later. So we'll create a mailing list from people who are expressing interest through the poll. Just wait for enough people to respond, and then we'll move on to the next one. You can scroll down the questions. Yeah, so if you've used your unique link to join the webinar, we'll be able to see who you are when you respond to this. Great. Any final responses? We're at 71 people at the moment. A few more seconds. 72, thank you. Great. Okay, so we'll just close the poll just now. Thanks, everybody. So thanks again to our speakers very much for joining, particularly in the middle of the night, Andre. And thank you very much for our audience. There will be another webinar coming up on another topic Thank you, and that's the end.